Can you hear me?
Yes, we can hear you.
Okay, thank you very much. Sorry, I have a very poor network. I'm standing somewhere currently. I hope the network doesn't disappear. Okay, so today I'll be talking on acyanotic congenital heart disease, the left to right shunt. And I'll be doing so under the following headlines. As a form of introduction, acyanotic heart disease is a congenital heart disease with structural malformation of the heart and great vessels. Cyanosis is not seen in acyanotic heart disease, hence, while the name is acyanotic heart disease. And as we all know, cyanosis means blue and acyanotic means not blue. Acyanotic heart diseases are characterized by a left to right shunt. Symptoms depend on the extent of the malformation. Congenital heart diseases are caused by disruption of normal sequence of cardiac morphogenesis. Congenital heart diseases may lead to formation of pathological connections between the right and left chambers, allowing blood to flow across a pressure gradient. So blood actually flows from places that have a higher pressure to the area of low pressure. And these shunts are classified as left to right shunts, or when it's flowing from right heart to the left side, it's called a right to left shunt. There are several causes of acyanotic congenital heart diseases. This includes, it could be idiopathic, it could be genetic. Other associated factors can actually be teratogenic from drug intake like thalidomide, alcohol intake by the mother, can also be caused by beta-acidemia. There are several acyanotic congenital heart diseases as listed here, but it's important for us to know that what we're presenting today is acyanotic heart diseases that cause left to right shunt. So not all of them cause left to right shunt. So this one's listed here are the acyanotic heart diseases that cause left to right shunt. The first one we're talking about today is atrial septal defect, ASD. Atrial septal defect is a congenital cardiac disorder that is caused by spontaneous malformation of the interatrial septum. ASD results from lack of sufficient tissue to completely separate. ASD results when there is lack of sufficient tissue to completely separate the atrials and can be classified according to the location where these ASD are found on the atrial septum. A brief embryology for us to understand how the atrial septum is formed. In the A picture, the septum premium actually grows caudally from the superior portion of the common atrium, and it grows downwards towards the endocardial cushion. The septum premium actually fuses with the endocardial cushion and closes the ostium premium, because the ostium premium is the first one, that is the space that is between the endocardial cushion and the septum premium when it starts forming. So the septum premium forms downward and closes the ostium premium by fusing with the endocardial cushion. Now, after the septum premium has fused with the endocardial cushion, another hole opens up in that septum premium, which is known as the ostium secundum. And a septum secundum grows to cover up this ostium secundum that has formed in the septum premium. So a second orifice, the ostium secundum, develops within the septum premium. And the second septum, called the septum secundum, develops from the right side of the septum premium to cover up this ostium secundum that has formed. The septum secundum covers the ostium secundum, but does not completely divide the atrium. It actually leaves a little space. And this persisting orifice that persists in the septum secundum is known as the foramen ovale. And this is like a space that actually helps in fetal circulation for blood flow from the right side to the left side to get into the systemic circulation, because it has already been oxygenated by the placenta before it got into the right atrium. So this foramen ovale is important in the fetus. There are different types of ASD. There is the ASD known as the ostium premium, there is the ostium secundum, there is the sinus venosum, and there is the coronary sinus defect. The ostium premium ASD, it accounts for about 15 to 20% of ASDs. So a premium ASD is a defect in the septum secundum caused by failure of the premium septum to fuse with the endocardial cushions at the base of the intra-atrial septum. So just like I earlier explained, if the premium septum doesn't fuse with the endocardial cushions at the base and there's a space in between the septum, premium, and the endocardial cushion, it actually forms the premium ASD. And this results from malalignment of the ventricular septum due to malformation of endocardial cushion rather than a decrease in the atrial septal tissue. Premium ASDs are nearly always associated with anomalies of the atrioventricular valves, particularly a cleft in the anterior mitral valve. When there's a combination of a premium ASD, a cleft mitral valve, and an inlet septal defect are seen, it is known as the partial AFB septal defect. This is a pictorial representation showing the premium ASD. I don't know how to show a cursor, but in this picture, if you see where the arrow is pointing at, is where the septum premium did not meet at the endocardial cushion. So that space there is actually a premium ASD. The other type of ASD is known as the ostium secundum ASD. And this accounts for the most part of all ASDs, accounts for about 70 to 75% of all ASDs. Septum secundum is a defect in the septum premium, resulting from the growth of the septum secundum or excessive absorption of the septum. So like I earlier explained, when the septum secundum is growing down to cover up the ostium secundum, if it doesn't cover it properly, it actually results to an ostium secundum ASD. Although most secundum ASDs are isolated defects, it's important to note that familial forms exist, and it can also be associated with other congenital heart abnormalities. When a secundum ASD is associated with a genetic disorder known as Holt-Oram syndrome, this is known as the heart-hand syndrome, where it's a congenital defect where a child is born without the radial bone in the forearm and also has a secundum ASD. It's also important to know that a combination of an ostium secundum ASD and rheumatic mitral stenosis is known as Lutzen-Bacher syndrome. This is a pictorial representation showing an ostium secundum, where the arrow is showing in between the septum secundum that is coming down and the septum premium that is identified as the red. The sinus venosus ASD is an abnormal fusion between the embryogenic sinus venosus and the atrium that causes the defects. Sinus venosus ASD represents an abnormality in the insertion of the superior or inferior vena cava, and this overrides the intra-atrial septum. In most cases, this defect lies superior in the atrial septum, near the entry of the superior vena cava. Often, there's associated anomalous drainage of the right superior pulmonary vein. The relatively uncommon inferior type is associated with partial anomalous drainage of the right inferior pulmonary vein. This is also a pictorial representation showing the sinus venosus ASD. The other form of ASD is the coronary sinus ASD. The coronary sinus defect is characterized by unroofed coronary sinus and persistent left superior vena cava that drains into the left atrium. This defect is actually the smallest of all ASDs. It accounts for about less than 1% of ASDs. It can result in desaturation due to right to left shunt into the left atrium. For epidemiology of ASD, I've already said this. The most common form of ASD is the ostium secundum, while the second is the ostium premium, and the sinus venosus is the least. ASDs are known to occur more in females with a female to male ratio of approximately 2:1. The magnitude of left to right shunts across an ASD depends on the size of the ASD and the compliance of the ventricles. When there is a small ASD, the left atrial pressure most times exceeds the right atrial pressure. And when there is a shunts in the flow of blood across ASDs is actually from the area of the area of higher pressure to the area of lower pressure. And when the left atrial pressure is more than the right atrial pressure, there's actually a left to right shunt. Shunting across interatrial septum is usually left to right and occurs predominantly in late ventricular systole and early diastole. With chronic left to right shunts, there is increased blood flow to the pulmonaries, and this would actually eventually lead to pulmonary hypertension. With chronic significant left to right shunts, it alters pulmonary vascular resistance, leading to pulmonary arterial hypertension. And when there's now increased pulmonary arterial hypertension, there is more pressure in the right side and the left side, and this causes reversal of the shunt and leads to Eisenmenger syndrome. By 40 years, 90% of patients who have ASD that are untreated will actually present with symptoms of heart failure. Clinical features of ASD, most patients actually are asymptomatic. But when, and this actually happens when there is actually small ASDs, but when ASDs are moderate to large, it may present with symptoms of easy fatigability, exertional dyspnea or palpitations. If undetected in childhood, symptoms may develop gradually over decades. And it's known that virtually most patients that have ASD who survive beyond the 6th decade are mostly symptomatic. For the physical examination, what we find actually depends on the degree of the left to right shunt and if there are now hemodynamic consequences from long-standing ASD that has resulted in possibly pulmonary hypertension. For the physical examinations, a hyperdynamic right ventricular impulse may be felt. Dilated pulmonary artery trunk may be palpated in the second left intercostal space. And also, it's noted that a wild and fixed split of S2 is an auscultatory hallmark of ASD. And this is actually because of the increased flow from the left side to the right side. Increased flow from the right atrium goes to the right ventricle and the pulmonary. So there's actually more blood flowing out to the pulmonary trunk. So there is actually a delay in closure of the pulmonary valve, leading to a wide and fixed split of S2 in ASD. For the heart murmurs that are seen in ASD, the shunt flow across ASD has a low velocity and produces too little turbulence to be audible. But when it is large, a mid-systolic pulmonary ejection murmur, which results from increased flow across the pulmonary valve, is heard. Patients who have large left to right shunts, we often hear a mid-diastolic murmur present at the lower sternal border because of increased flow across the tricuspid valve. In patients who have an ostium premium defect, ostium premium defect, as I earlier said, is most times associated with a cleft mitral valve. So these patients, you might actually hear a systolic murmur of the mitral regurgitation that is present. And when right ventricular failure develops, patients actually have pulmonary hypertension, and there is actually a pansystolic murmur can be heard across the tricuspid valve from tricuspid regurgitation. Investigations, chest X-ray can be done. Pulmonary artery is mostly prominent because of increased pulmonary flow. There is left atrial enlargement, and in echo, transthoracic echo can be used to document the types and sizes of ASD. The functional importance of a defect can be estimated by the size of the right ventricle. When a patient has when he has a dilated right ventricle, it tells you that there's increased blood flow to there's fluid overload and pressure overload on the right side. The presence or absence of right ventricular volume overload, and also estimation of the QPQS. The QPQS estimation is more like, excuse me, please. QPQS is like estimating the pressure in the pulmonary circulation and that in the systolic circulation, in the systemic circulation. Indirect measurement of pulmonary artery pressure can be obtained by Doppler velocity of the tricuspid regurgitation jet, which we can use to measure the pulmonary systolic pressure. Contrast echo can provide additional confirmation. A right to left shunt can be detected by visualizing microcavitation bubbles in the left atrium and in the left ventricle. An MRI can also be used, which can tell us the position of the ASD. ECG done in these patients can be normal in people who have small ASD. But when there is a sinus, there are actually different ECG findings for different types of the ASD, as I earlier said. For the sinus venosus, we have left axis deviation and negative P waves in the inferior leads in lead 2 and AVF, and a positive in AVL. The reason for the negative P waves is known that there's actually a leftward shift in the ectopic pacemaker. That is, the pacemaker actually shifts because this ASD actually occurs around the SA node. So the SA node now is no more is no more the site of the primary pacemaker. So like an ectopic pacemaker results, which gives negative P waves in lead 3 and AVF. For the ostium premium defect, the commonest seen is a first-degree AV block, which is a prolonged PR interval. It can actually be seen in most AS, just that it's commonest in ostium premium. Complete heart block is seen, and at the same time, there is right bundle branch block. There's usually a right bundle branch block, which is seen as the RSR pattern in V1. For the ostium secundum ASDs, is also a right axis deviation. Right bundle branch pattern is seen, and it's usually a normal sinus rhythm. A notch on the arrow wave in the inferior leads is usually seen in the ECG of ostium secundum, and this pattern is known as the crochetage. This is a pictorial representation of the ECG of the ostium secundum. If you look at it, it's actually noted that a notch is usually seen in the arrow waves of the ECG, and it's usually seen in the inferior leads, lead 2, 3, and AVF. That's in the arrow wave, you actually see a little notch. If you look at where the arrows are pointing, you could see it, and this is known as the crochetage sign in ostium secundum. Complications that can occur are atrial arrhythmias from dilatation of the left atrium and from the right atrium and right ventricle, and the left atrium can lead to arrhythmias. Pulmonary hypertension is seen when there is now Acyanotic syndrome and reversal of the shunt. Cyanosis is seen as complication when the Acyanotic syndrome has developed, and there could be paradoxical embolism where a deep venous thrombosis clots or a venous clot gets across the ASD and gets into the left circulation, the systemic circulation. For the management, ASD is addressed surgically or through interventional catheterization. No specific medical therapy is available, but however, when these patients develop arrhythmias or heart failure medication is given and antiarrhythmic medications are given. Indication for intervention, for most times, for you to determine if you intervene in an ASD, is mostly the size of the ASD and the location, and also the hemodynamic impact of left to right shunt. Important to note that in the presence of pulmonary arterial hypertension, surgeries are contraindicated. In general, elective closure is advised for all ASDs with evidence of right ventricular overload, where the pulmonary flow to systemic flow is greater than 1.5. That's a QPQS ratio of greater than 1.5. Actually necessitates that patients should have surgery. Lack of symptoms is not a contraindication for repair. So if spontaneous closure of ASD is common in children, but mostly unlikely in adults. Contraindications for doing a surgery: if a patient doesn't have a clinically significant shunt, that is, you measure the QPQS and it's actually less than 0.7. Patients who have severe pulmonary hypertension, if you make a diagnosis in pregnancy, or if patients now have severe left to right ventricular dysfunction, surgery is contraindicated. Device closure of secundum ASD can actually occur where it's done under fluoroscopy through transesophageal echo or intracardiac echoes. Indication for device closure is same as surgical closure, but the selection criteria is stricter. For the surgery, the procedure is generally performed by a midline stenotomy. Surgical mortality in adults without pulmonary hypertension is less than 1%. Surgical closure of ASD in adult life does not prevent atrial fibrillation, flutter, or stroke. So if a patient has already gone ahead to have maybe a dilated left atrium from complications of overload and has developed atrial fibrillation or any form of arrhythmia, surgery doesn't correct this. Pregnancy is tolerated in patients who have ASD and also after closure. Pregnancy, however, is contraindicated in people who now have severe pulmonary hypertension from Acyanotic syndrome. The other one we're going to talk about today is patent foramen ovale. Patent foramen ovale is a flap-like opening between the atrial septum premium and secundum at the location of fossa ovalis that persists after 1 year. With increasing evidence that patent foramen ovale is a culprit in paradoxical embolic events, its importance is being reevaluated. To briefly talk on the anatomy, the foramen ovale is a tunnel-like space between the overlying septum secundum and septum premium, and typically closes in 75% of people. 1 second, please. Sorry, please. The foramen ovale is a tunnel-like shape, is a tunnel-like space between the overlying septum secundum and septum premium, and it typically closes in 75% of people at birth by the fusion of the septum premium and secundum. In utero, the foramen ovale is necessary for blood flow across the fetal atrial septum. When oxygenated blood gets into the right atrium from the placenta, because the pulmonary circulation is not yet functional, there's actually a patent foramen ovale that allows blood to flow from the right atrium, passes the foramen ovale and gets into the systemic circulation, into the left atrium and goes into the systemic circulation and returns back to the placenta. In approximately 25% of people, patent foramen ovale persists into adulthood. Patent foramen ovale is an anatomical interatrial communication with potential for right to left shunt. And it's important to know that most times it can be associated with other cardiac anomalies. This is a pictorial representation showing a patent foramen ovale if you look at the picture above. Patent foramen ovale is detected in about 10 to 15% of patients. The difference is probably due to, the prevalence and size of patent foramen ovale is similar in both males and female, and it declines progressively with age. To talk of the pathophysiology, like I earlier said, foramen ovale serves as a conduit for right to left shunts. But once after birth, pulmonary circulation is established, the left atrial pressure increases and allows functional closure of the foramen ovale. When foramen ovale persists after birth, it's usually about 3.4 millimeters, but as the patient progresses in age, it actually stretches further. Any condition that will increase right atrial pressure more than left atrial pressure can actually induce a paradoxical flow and increase the flow from left to right, and increase the flow of blood from the shunt. PFOs may serve as either a conduit for paradoxical embolism from the venous side to the systemic circulation. There is a risk of cryptogenic stroke in people who have large PFOs. It's important to note that when they are doing physiologic maneuvers like Valsalva maneuvers that increase pressures on the right side, it actually favors a right to left shunt, and this can actually cause paradoxical embolization. Young patients who have cryptogenic stroke have significantly higher incidence of PFOs. This association is controversial in older patient population because older patients population who have been noticed to have PFOs most times don't have history of cryptogenic stroke. They have stroke from other causes. For the clinical features, patients most times may be asymptomatic. Patients have history of stroke or transient ischemic events of undefined etiology. Also, it's important to know that migraine and migraine-like symptoms have been associated to PFO, and PFO closure has been evaluated as a treatment of migraine headache in patients who have been noted to have PFOs. Investigations to do include an echocardiography. Patent foramen ovale can be detected with color flow Doppler. A transthoracic, a transesophageal, and intracardiac echo can be used. But it's important to know that transesophageal echo and ICE enable visualization of PFOs than transthoracic echo. A three-dimensional echo provides direct visualization of PFO anatomy and surrounding structures. An important investigation in PFO is contrast echocardiography. It's usually performed to detect even very small PFO. After obtaining visualization of the atrial septum, either through transesophageal or intracardiac, a bolus of agitated saline is injected into the antecubital fossa. This agitated saline appears in the right atrium. The study is actually for you to check if micro bubbles will cross from the right atrium to the left atrium. So it's important to do maneuvers that will increase right-sided pressure, like Valsalva maneuver, so that when you increase the pressure on the right side, it's greater than. Sorry, please, I got a call, but this.
Sister's exercise little patients should be back soonest.
Hello, can I be heard? Sorry, my network is bad. The call was coming in.
Yes,
Hello.
you can be heard. You can
We can hear
be
you
heard.
now.
You can be heard. You can share your screen. Okay, a little more patients. She earlier complained that she had issues with her network. Her network is fluctuating. So please let's just exercise little patients. She'll be back. Okay, if in 3 minutes time she doesn't log in, you would need to move over to the next section because she's been having network issues. So in 10 minutes time, that's by 8:35. If by 8:35 doesn't log in, we move on to the next section, which is the MCQs. Thank you.
Do you have a number? Can you share it so I can call her to know what's happening?
Okay, I have a number. Okay, you want me to share it? I should send it to you. So I didn't get
Yes,
you, sir.
maybe. Yeah, WhatsApp. Let's share it.
Okay, let me send it to you. Thank you, sir.
You're welcome. Hello, Prof. Sir. Welcome, sir. Prof. Sir. Welcome, sir. We are so glad to have you, sir. All right, sir. Thank you, sir. Amen, sir. Thank you, sir. Chief was okay. Thank you for coming, sir.
Chief, good evening, sir. Good evening, Prof, sir.
She's trying to reconnect. I just called her on phone now.
All right, so let's just be doing housewarming while she records. All right. Thank you. Thank you, Chief Alex Itubi, for coming. Thank you. Our great Temilade Adeyanju. Thank you. Thank you for coming. Thank you, Alison.
Good evening, Chief. Good evening, Chief, sir.
Yes.
Thank you. Good evening, Prof.
I salute everybody.
Prof, good evening,
Hello.
sir. Dr. Kopi, good evening.
Good evening.
I'm very
Thank you
sorry.
so
I
much.
was talking to myself. I think the phone went
All right.
out. Sorry.
All right. Thank you. Yeah.
I don't know where I stopped. Where you stopped hearing me, please. Where did I stop? Because I had gone far talking to myself. Hello. So can I go ahead? So the VSDs, as I said, there are 4 types of ventricular septal defect, as listed below. For the infundibular type, can I be heard, please? Am I heard?
You can be heard. Yes, you can be heard.
Thank you. Okay. Thank you. So the infundibular type is also known as the supracrystal. It results when there is deficiency in the septum above and anterior to the crista supraventricularis, and is usually beneath the aortic and pulmonary valves. The infundibular VSDs are common in Asians and accounts for 1/3 of VSDs. This is a pictorial representation of the supracrystal, as I try to explain here. So if you look at the picture above, you actually see I don't know how to use the cursor here, but the color flow, it's seen as where there is the shunt in between the close to the right ventricle and the left ventricle. This is the parasternal short axis view showing where the supracrystal VSD is. It's important to note that in this short axis view, it's actually known that the supracrystal VSD is closer to the pulmonary valve than the tricuspid valve. The other type of VSD noted is the membranous VSD. The membranous VSD results from deficiency of the membranous septum and is the most common type of VSD in adults. This defect is inferior is inferior to the crista supraventricularis, unlike the supracristal that I said that is superior to it, but this one is inferior to the crista superiaris, to the supraventricularis, and borders the septal leaflet of the tricuspid valve. The defect may extend into the muscular septum and is then referred to as perimembranous VSD. This is a pictorial representation trying to show the crista, trying to show the membranous defect, which is known as the MS. The membranous defect in parasternal short axis is actually closer to the tricuspid valve, while the infundibular defect, which is also the crista defect, is actually the one closer to the pulmonary valve. The inlet VSD, which is a type 3 VSD, it results from deficiency of the inlet septum located beneath both the mitral and tricuspid valve. This defect is largely atypically large and often associated with Down syndrome. This is an apical 4-chamber view, though it's actually upside down. It's actually where you see the inlet VSD in between the right ventricle and the left ventricle. For the muscular VSD, it accounts for about 5 to 20% of VSDs in adults, and are bordered only by the muscle within the trabecular spectrum, away from the cardiac valve. The muscular defects are usually small, sometimes they may be large, but mostly small, and occasionally has multiple exits resembling the Swiss cheese. Okay, this is a picture showing using colors to differentiate the parts of the different types of VSDs, as I earlier said. If we look at the picture above on the right side, where you have the color flow, the pink one, which is closer to the pulmonary valve, is the one I said is the crista, while the one that is green, closer to the tricuspid valve, is the perimembranous or the membranous VSD. Clinical manifestations. The clinical manifestations of VSD in adults vary from the size and the hemodynamic effects of the defect. The direction and severity of shunt is determined by the VSD functional size. A small VSD will cause a left to right shunt is considered as simple congenital heart defect, whereas a VSD that has other additional abnormalities or has a bigger shunt is considered to be complex. Small VSDs are associated with small left to right shunts, and small VSDs are noted when the QPQ is less than 1.5. The orifice of small VSD is usually less than 25% of the aortic annular diameter. And most times in these patients, there is usually no left ventricular volume overload, and they rarely develop pulmonary hypertension. Most small isolated muscular and perimembranous VSD close spontaneously during adulthood. Adults who have isolated small restrictive VSD that cause very small left to right shunts are referred to maladie de Rouget. They are mostly asymptomatic, but they actually have a systolic murmur with a palpable trail because it's actually a very small VSD, so there is increased pressure of blood flowing across it from the left to the right parts. For moderate VSDs, when the QPQS is greater than 1.5 but less than 2.1, and the defect most times is greater than 25% of the aortic annulus diameter but less than 75%. People who have this most times develop heart failure symptoms. If it's seen in children, when children get older, most times VSDs that are moderate size may actually get smaller and become either small or close entirely. However, adults who have moderate restrictive defects may not completely close and may subsequently develop pulmonary hypertension. For large VSDs, they are non-restricted VSDs, and they are greater than 75% of the aortic annulus diameter. There is initially large left to right shunts, and here the QPQS is greater than or equal to 2.1. These patients often have left ventricular volume overload, heart failure, and if not corrected early, they develop pulmonary hypertension early. And these VSDs are generally closed during first year of life. Complications of VSD. If a large VSD remains uncorrected, it will cause progressive pulmonary hypertension and lead to long-standing unobstructed pulmonary flow. With progressive increase in pulmonary vascular resistance, there is increase in right ventricular pressure, and this leads to reversal of the shunt, resulting to a right to left shunt, and there is now hypoxemia and cyanosis. This reversal of left to right shunt to right to left shunt because of the increased pulmonary resistance is known as the Eisenmenger syndrome. Eisenmenger syndrome is associated in VSD. When Eisenmenger syndrome occurs in VSD, it is known as Eisenmenger complex. Clinical features, most times, if they are small, asymptomatic, may develop heart failure symptoms and could have arrhythmias and have palpitations. Physical examination, it actually reviews a harsh murmur, has a high frequency, and it is pansystolic, about grade 3 to grade 4, and had a maximal intensity at the left sternal border between the third and fourth intercostal space. It's important to note that this murmur is almost the same as the tricuspid murmur and also head around the tricuspid area. So, but the important thing to note is that the tricuspid murmur, with inspiration, there is increased flow in the right side. So it actually increases, right-sided murmur increase with inspiration. But however, in VSD, this murmur is increased with expiration. The smaller the VSD, the louder the murmur. Small VSDs cause high frequency systolic murmur. With pulmonary hypertension, the murmur actually is now no more throughout the systole, actually occurs in early systole. And with development of Eisenmenger syndrome, with development of Eisenmenger complex, there is now no murmur across the VSD because it's now like the pressures equalize and there's a reversal of shunts. What is now heard at this point is a mid-systolic murmur due to dilation of the pulmonary trunk, or a holosystolic murmur related to tricuspid valve regurgitation from pulmonary hypertension. When VSD is complicated and Eisenmenger syndrome develops, patients could develop central cyanosis and clogged digits. VSDs can be associated with other heart lesions like aortic regurgitation, tricuspid regurgitation. For investigations, ECG is done. It may be normal when it is small, but there is actually, in larger defects, conduction, right bundle branch block, or interventricular conduction is noted. Because of the increased left ventricular overload that happens, there is evidence of left atrial enlargement on ECG, like there's P mitrale. LV enlargement could also be seen from ECG, like Sokoloyon criteria. In presence of Eisenmenger complex, the ECG now reflects that there is increased right ventricular pressure. So things like right axis deviation, right atrial enlargement, and right ventricular hypertrophy could be noted. And also, because initially there's also left ventricular enlargement, patient could have biventricular hypertrophy. For the chest X-ray, there is increased pulmonary vascular markings from increased blood pressure to the pulmonaries from the VSD. There is also cardiomegaly, and pulmonary arterial enlargement is noted on the chest X-ray. With prominence of Eisenmenger complex, there is right ventricular hypertrophy on the chest X-ray. The most important test needed in evaluating a patient with VSD is actually an echocardiogram. Parasternal long axis view actually helps visualization of most types of the VSDs. Parasternal short axis view, VSDs are also seen clearly. And in parasternal short axis view, the membranous defect is seen closer to the tricuspid valve, while the infundibular defect is seen closer to the pulmonary valve. Also, the membranous VSD is seen mostly in aortic 5. When you do the apical 5-chamber view, the membranous part is mostly seen. It's important to know that transesophageal echo is reserved for patients who have suboptimal transthoracic echo windows. This is a pictorial representation. Exercise testing is also useful in these patients. So these patients, when they are unable to achieve 70% of functional aerobic capacity, they are said to be abnormal, even if they are not symptomatic, and they can go ahead to have intervention. Indications for intervention: when patients have a VSD and in the presence of VSD and patient is symptomatic, and there is no pulmonary hypertension, it is important to do surgical intervention at this time. However, if pulmonary hypertension is present, it is not advised, especially when there is severe pulmonary hypertension, is a contraindication. Other indications to close a VSD would be when the patient has mild aortic regurgitation and if there is history of recurrent endocarditis. Surgical closure is performed and there is a high closure rate in surgical closure. Patch leaks are not uncommon, but most times if it happens, a reoperation could be done. Device closure is also used, but it's important to note that muscular VSDs has been closed by transcatheter, but perimembranous, the closure that has been done through device closure, there have not been any good results because it's closer to the aortic valve, and most times with device closure, the aortic valve may be damaged. Patients who have VSDs, small, can actually go ahead to have children, but when there is a Semenja complex, it is not advised because of increased mortality. The next one to discuss is patent ductus arteriosus. A ductus arteriosus is a fetal vascular connection between the main pulmonary artery and the aorta that diverts blood.
Dr. You have like 10 more minutes left. You have like 10 more minutes left to round off. Thank you.
Okay, then. So patent ductus arteriosus is a connection between the main pulmonary artery and the aorta that diverts blood away from the pulmonary bed. It usually closes after birth. When there is persistent communication between the descending aorta and the pulmonary artery, it results in the PDA and it results in left to right shunts. For the fetal circulation, the right ventricle, like we know, blood flows when it flows into the right atrium, crosses foramen ovale. Anyone that still goes down to the right ventricle, as it gets into the pulmonary trunk, it doesn't get to the lungs because the lungs are not yet functional. It passes through this ductus arteriosus and gets into the systemic circulation. So, but usually after birth, it's noted that for fetal ductus arteriosus, it actually kept patents from the placenta that produces prostaglandin E2. So when the ductus arteriosus doesn't close, anti-inflammatory NSAIDs are actually given like indomethacin to help block the role of the prostaglandins to help close the ductus arteriosus patency. It's important to note that in women who take NSAIDs, like during maternal use, can actually cause fetal closure of ductus arteriosus. This is a pictorial representation showing where the ductus arteriosus connects to the descending aorta and the pulmonary trunk. These are etiology, clinical manifestations. When there are small, you can actually determine whether it's small, large, or moderate from the QPQS. Patient can be asymptomatic, but adults who have persistent PDA can go undiagnosed and only present when there is overload and results in symptoms of heart failure or atrial arrhythmia. For the physical examination, patient has a continuous murmur, which is heard at the first or second left intercostal space below the clavicle. The louder continuous or machinery murmur is noted with a wild systemic pulse pressure. The wild pulse pressure results from the aortic diastolic runoff when the blood flows from the aorta from the left side to the right side into the pulmonary trunk and can also cause a displaced apex. Adults with large uncorrected PDA eventually have short systolic ejection murmur when they finally develop a Semenja complex. Investigations, ECG should be done. In ECG, we can actually see biventricular hypertrophy and left atrial enlargement. For the chest radiograph, there is prominent main pulmonary artery segments, pulmonary markings from increased pulmonary flow. Echo, the PDA can be viewed in many views. Most commonly, it's imaged in the parasternal and suprasternal views. This is a pictorial representation. If you look at the labeling, you will see where the patent ductus arteriosus is seen, usually connects the left pulmonary artery, that's around the bifurcation. It connects the left pulmonary artery to the descending aorta. And if you put a color flow, you see the leak there. Indications for intervention. In the presence of severe pulmonary hypertension, when a Symenger complex syndrome has developed, its closure is not indicated. There is no debate on when to close. As long as there is a left to right shunt and it's significant, it's important to close it irrespective of the age. Surgical closure can be done, and at the same time, device closure can be done. For follow-up, after device occlusion, patient can still be followed up after 6 months. But however, during the period of device closure for 6 months, patients should actually be on anticoagulants for about up to 6 months. In conclusion, acyanotic congenital heart defects are cardiac malformations of the walls of the heart, from the atrium, ventricles, blood vessels, and they could actually result from left to right shunt. But it's important to note that with complications and development of a Symenger syndrome, there's a reversal and results to right to left shunts. Different heart murmurs are heard, and this can help make a diagnosis. Surgical or transcatheter repair is indicated in patients. Pharmacological therapy is indicated when the patients have developed heart failure or Symenger and have arrhythmias. Thank you.
Okay, Dr. Ojo. Okay, thank you so much. Okay, Dr. Ojo, okay, you can have the floor. Dr. Ojo, thank you.
Yes, thank you very much. I want to appreciate Dr. Winye for that lucid presentation, despite the issues of network. I think it's a very common problem. Thank you very much for your presentation. I want to also welcome Prof. I saw that Prof is on the call. So thank you for your continuous guidance and your presence. We're happy to see you. So I don't know if there are any